Hello, everybody. It's Chip Rogers, President and CEO of the American Hotel and Lodging Association. So glad that you're with us. Boy, do we have a timely set of speakers today. The topic, you've probably heard of it, this thing called the coronavirus and the Omicron variant. We're going to talk a lot about that today. Now, look, before we dive into this, we've got to say thanks to our sponsors. We wouldn't be able to do this without their support. We really appreciate them, not just supporting AHLA, but always standing by the entire industry, especially during our time of great need over the last 2 years. So thanks again to Foodbuy, Hodges, Ward Elliott, and Spencer Stewart. Let's dive right in. Today, we're super excited and really blessed to have Dr. Scott Gottlieb with us. Dr. Gottlieb served as, he is a physician, of course, but he served as the 23rd commissioner of the U.S. Food and Drug Administration. His work focuses on advancing public health. He serves on the boards of both Pfizer and Illumina. He is a fellow, a resident fellow at the American Enterprise Institute, and he is a New York Times bestseller. And his title of his book, which I would suggest everyone get and read, Uncontrolled Spread, Why COVID-19 Crushed Us and How We Can Defeat the Next Pandemic. Dr. Gottlieb, so good to have you with us today.
Thanks a lot. Thanks for having me.
So boy, this is changing not just by the day, but really by the hour, especially with the Omicron. It was interesting. I was just speaking to a large group of hotel executives, and it reminded them what we know today may not be what we know tomorrow. And I know you just got updated information, but before we dive on that, I want to hear your thoughts on Omicron and how does this differ from Delta, from Beta, from everything we've seen up to this point?
Yeah, if you look at the gene sequence of this variant, it's heavily mutated. So it's very different than the Delta variant or the other variants that we've seen. It incorporates a lot of the mutations that we've seen so far in other variants, but it also incorporates some mutations that we've never seen before. And it seems to represent what I would call divergent evolution, basically a different evolutionary path. There were many of us, including me, who thought that Delta would be the last major wave of infection and future mutations would happen within the Delta lineage because Delta itself was so transmissible that it would sort of crowd everything else out. And eventually Delta itself would mutate, it would find ways to evade our immunity, but it would be sort of the baseline level of infection. So people who had Delta immunity would be protected from subsequent Delta infection to some degree. What this new variant represents is something that took a completely different evolutionary turn over the last year, and it was hiding somewhere, we don't know where, continuing to presumably replicate and mutate, and then suddenly reemerged. And so if you look at the tree, the sort of genealogical tree of tracing this back, it appears that there was an infection that happened at some point, probably in early 2021, maybe even in 2020, and it went somewhere. So it either went into an individual who became chronically infected with that strain or went into an animal reservoir, continued to mutate in that environment, either in the confines of a single individual or in an animal reservoir, and then reemerged, reinfected someone who then went on to reinfect other people and had some, super spreading events. And then you had an outbreak in South Africa. That's the prevailing wisdom. That's sort of the conventional wisdom. The other possibility, and I think it's declining in possibility. I think that this was a bigger possibility 2 weeks ago, but some of the subsequent data has sort of diminished this as a possibility. But I would say this is still on the table. The other possibility is that this was spreading sort of cryptically, furtively in the population. It isn't quite as transmissible as we think, or it's causing a lot of subclinical illness. So we weren't picking it up in the places where it was spreading. And then it got into some super spreading events and sort of exploded in prevalence. And now that Delta has declined in South Africa and you see an uptick in cases, you're able to more easily identify this sort of new COVID strain outbreak. I think that's less likely to be the case given the velocity of the spread that we've seen in South Africa. But I think that possibility is still on the table, that this is something that actually has been around longer than we think, spreading at lower levels and has evaded detection in regions without the kind of surveillance that the UK has or other countries that do a lot of sequencing.
So when we think about mutations, and for all the lay people, which I'm assuming is just about everybody listening to you right now, what is the lifespan of a mutation? Does it go on forever? Does it die off? Does it recreate itself? Explain a little bit more about that.
Yeah, well, look, we've seen many mutations of this SARS-CoV-2, this virus that became epidemic in certain regions and didn't become globally epidemic because they became outcompeted by other variants that were more contagious, but afforded a level of immunity that effectively crowded out the spread of a would-be new variant. So, 1351, the old South African variant, became epidemic in South Africa, never really spread in appreciable levels outside South Africa, and certainly didn't spread in the United States at any really appreciable level. P1, which was a variant that was epidemic at one point in parts of Brazil, again, never really got a foothold in the United States because B117 arrived. First of all, we got a lot of vaccine immunity into the population that was protective against those variants. B117 arrived and provided more immunity, acquired immunity. That immunity was protective against those other variants. And then Delta, which is highly contagious, also provided immunity against those other variants. What's concerning about this new variant is it seems to spread by piercing the immunity that we've acquired. So, it does appear to be innately more transmissible than some of the old variants, although we don't fully know that yet. But it does appear to be more transmissible because it's able to evade the immunity that we've acquired. And the question is, how much is it going to evade the immunity that's in the US population? So it seems to be reinfecting people who previously had Delta infection in South Africa. We know that pretty reliably now. The South Africans have done good analysis demonstrating that a lot of the people, if not most of the people who are presenting with infection previously were infected with Delta. And South Africa had a devastating Delta wave. The presumption was upwards of 90% of people have had COVID in South Africa who haven't been vaccinated. So it would stand to reason that people who are getting this new variant are getting reinfected. And that may be one of the reasons why we're not seeing as much serious illness, that people who are getting infected with this have a baseline level of immunity. And so the question is, how will this behave in the United States? We have a different composition of immunity here in the US. We have a lot of Delta infection, so we're not unlike South Africa in that regard. But we also have higher levels of vaccination. We probably have significantly higher levels of people who've been both infected and vaccinated. We are rolling out boosters, and the boosters do behave almost like a different vaccine in terms of how they induce a much, not just more antibodies, but a much broader complement of antibodies that should be protective against more variants. We also have a smaller population of people who are immunocompromised. In South Africa, upwards in the Gauteng province, where this is spreading, upwards of 20% of people are HIV positive. So they have some immunocompromised state. Here in the United States, probably about 3% of Americans are classified as immunocompromised. The HIV positivity rate's well below 1%. So you have a different background level of vulnerability too. And again, we don't know where this is spreading, what demographic this is spreading in South Africa. So we don't know that it's hitting people who have some kind of immunocompromised state, but that certainly creates more vulnerability. So there are things that are different between the two regions in terms of the immunity that we've acquired and the immunity that's been acquired in South Africa. But that doesn't mean that it doesn't have the potential to spread here. And the fear is that even if it's causing subclinical illness in most cases or milder illness, in part because people who are getting infected with it have a baseline level of immunity because it's spreading by reinfecting people who've been previously infected. Even if it makes only a small percentage of people sick, a small percentage of a very big number is still a big number. And then the other question on the table is, if this isn't innately less virulent, if it isn't an innately less dangerous strain, but the reason why it's presenting as less serious illness based on what we've observed so far, and that data is very tentative, so we shouldn't draw that conclusion. But if in fact it is concluded that this is causing less serious illness on the whole, is it because it's innately less virulent, less dangerous, or is it because it's simply reinfecting people who have a baseline level of immunity and have T cells and memory B cells and other components of immunity that are able to fight off disease, even if they're not able to protect themselves from getting infected in the first place? And if it's that scenario, if the reason why there's less serious illness being observed is because people who are getting this have some level of immunity, you have to worry about how it will behave in populations that are immune preserved, that haven't been vaccinated and haven't been exposed to previous coronavirus. And so if you think about what is the largest population of people who have been protected from infection and also haven't been vaccinated, you have to worry about young children. You have to worry about toddlers and how this virus would behave in that demographic. If it is an innately more virulent virus, but it's just not behaving that way because the people who are getting it so far are people who've previously been infected.
So you talk a lot about this, and we all hear this, but maybe you could bring a little clarity to it. People who have previously been infected, people that have been vaccinated, many people that have both been previously infected and vaccinated. Can you help walk us through the difference and the protections of kind of each of those groups?
Yeah, so there was some good data yesterday. Two studies. One I retweeted them both. One Eric Topol had retweeted, and I retweeted him. I hate to talk about Twitter too much. And the other one was by Jesse Bloom, that looked at some modeling on how our protection would fare up, would line up against this new variant. And they looked in particular at a variant that was created in a laboratory, sort of a model variant that was heavily mutated and designed to evade our immunity, and in some respects looks like this new variant. So, fortuitously, some researchers who are very good tried to create sort of the scariest variant they could, and they came up with something, this was months ago, that looks somewhat like what emerged, but it's actually in some respects worse than what emerged. And what they found and what the modeling shows is that the antibodies produced by 2 doses of vaccine probably aren't going to be that protective. They'll still offer a measure of protection, but they're significantly less likely to neutralize the virus and protect infection. And remember, there's a difference between infection and disease. So we're talking about infection here, and then there's protection against disease. So I'll sort of get to that. But it does appear that people who've been infected and vaccinated, and people who've had 3 doses of vaccine, who have a properly boosted vaccine, do have a higher measure of protection against that sort of scary variant that was created in the laboratory. And so if you impute those results to this, and you think this is going to behave like that variant did that they created, which they obviously just tested in a laboratory, they didn't infect people with it, so they don't know really how it's going to behave clinically, you would surmise that there's going to be a level of protection against this variant, that you're going to have a meaningful level of protection against this variant from the vaccines and from people who are vaccinated and then who are infected and then subsequently vaccinated. Now, getting back to that point about protection against infection and protection against disease, what we're seeing is that people who previously were infected with Delta and people who only get 2 doses of vaccine, perhaps, although we don't have good data coming out of South Africa on the vaccinated population, but certainly people who've had Delta infection seem to not be afforded a very high measure of protection against infection, because we see people getting reinfected. That's very different than having protection against developing a symptomatic disease and certainly severe disease, because people who get infected still have other components. So the antibodies are what protect against infection, the circulating antibodies. If it pierces those circulating antibodies, you have other components of immunity, particularly your memory B cells, which are cells that can reconstitute themselves and start churning out antibodies in response to the virus. It's sort of programmed to have memory. And then you have T cells, and the T cells attack the virus and prevent disease. And the T cells should be preserved. T cells that are primed to attack coronavirus, this new variant hasn't mutated in a way that it changed the elements that the T cells recognize. So that T cell immunity should be preserved, and that should be protective. And that, again, may be why we're seeing people get infected at a very high rate, but the hospitalizations so far aren't going up. So the vaccines could be protective. And then final point about the booster vaccine, the reason why people like me and others have a reasonable degree of confidence that a properly boosted vaccine is going to offer a meaningful level of protection, at least against severe disease and probably against symptomatic disease, is that what we saw with the boosted vaccine was that it didn't just produce more antibodies, it produced what we call a polyclonal effect, where you were getting antibodies against more targets on the surface of the virus. And so we said all along, the presumption would be that a boost after that booster, you would be more protected against variants. And that's why I always said, when people would say, well, natural immunity, if I go out and get infected and then have immunity from infection, that's going to be just as good as being vaccinated. We would often say, and I said, if you get Delta infection, you might be better protected against a subsequent Delta infection than if you've gotten vaccinated. Maybe. I mean, the data's on both sides of that question, but you're not going to be protected against everything else as well. The vaccine will induce protection that's broader, that protects against a wider range of variants than just getting infected with Delta. So a lot of the people who probably have been infected with Delta haven't been vaccinated. Those are the people who are going to be vulnerable to infection by this new variant.
So you bring up the difference between infection, disease, and I think what I would assume is our primary goal is preventing severe disease. And how, as vaccines, as more of the population becomes vaccinated, as more people have natural immunity, as more people get booster shots, how close are we in the US to that point of preventing severe disease, recognizing that infection may still happen, but that's not really what we're aimed at. We're aimed at preventing the severe disease, right?
Yeah, I think that there's two elements here. I mean, there's the public health sort of clinical element, which you're getting at, and then there's the American psychology element. And I think, there's components of our population now that are done with COVID. They've been vaccinated. They recognize at some point in their life they're going to get this infection, and they're going about their lives in a normal way. But there are still, I think, a sizable portion of the population that still doesn't want to get this infection, doesn't want to bring it home to their family, and are going to continue to take measures to try to avoid infection, including limiting their activity, obviously wearing masks in public. And I think that that's a sizable component. And I think, even if we get into a realm where you have variants spreading that are causing far less death and disease on the whole, I think, psychologically, I'm not sure the public's going to migrate to a view that this is something that's going to circulate. This has become less fearsome, and we're going to need to manage this in the same way we manage the flu. Although I think we're too complacent about the flu and make ourselves too excessively vulnerable to the flu. We should be doing more to prevent that. But we've learned to live with it. I think we eventually get there. I'm not sure that Omicron is going to be the variant that kind of takes us there. I think it's going to take a little longer. And Omicron still is probably going to, if it does spread, I mean, if you sort of believe that sort of conventional wisdom base case 70% scenario, that this is highly transmissible, it pierces the immunity that's been acquired in populations, even ours, it's going to spread around the world. I think what you end up having here is not necessarily another huge Delta wave where you see the extreme death and disease that Delta causes. Because after Delta courses through our population, we're going to have probably 90% of the population with some level of immunity, either from vaccination, infection, or both. But you're going to see something where it causes a lot of infection. And when it causes a lot of infection, there's going to be people who get sick, get hospitalized. And then if there are pockets of vulnerability, which I hope isn't the case, and Josh can speak to this, I mean, he has far more expertise in this than me, but if there are pockets of vulnerability and they're particularly around people who are, as I mentioned, sort of immune naive, younger people, children, toddlers, I think that's going to be something that, from a society standpoint, we're going to want to be vigilant against the spread of this virus if we start seeing that. And that's what I worry about it. Again, there's nothing really to indicate that that's the case, but I worry about something where we have a little bit of a reassurance because we're seeing outcomes aren't so bad, but where it's so far spreading is in people who have some baseline level of immunity. We haven't seen how it behaves in people who don't. So if you let it become widely epidemic in the US, eventually it's going to get into those pockets of vulnerability. That's the scenario I worry about here in the US. Again, you can make a case that we have a different complement of immunity and it's going to be a backstop against this, and you're not going to see the infection levels get as high as what you're observing in the Gauteng province. Infection levels, as you and I were talking about before we came on with the data that came out today, infection levels do appear to be kind of peaking in South Africa. We don't know if that's because they've reached the upper limit of their testing, or in fact, maybe this epidemic curve is starting to peak. And what we've observed in South Africa isn't the beginning of a very steep epidemic, but we kind of caught it late, and we caught the epidemic when it was well underway. And that gets to that sort of other scenario where this had been spreading longer than we think and wasn't getting detected. And we just sort of detected it more recently because it became explosive, but we caught it at the top, not at the beginning. And there is a possibility of that. A lot of what we're basing our assumptions on when this first started to spread is sequencing data, looking at the genetic diversity and the different sequences that are being sampled in South Africa. But if they've oversampled a cluster of infections, which I believe they did, they could be underestimating the actual diversity of this virus in that environment, and it could have been spreading far longer than what they're estimating right now. Right now, the estimate is this emerged at some point in October. It's possible it emerged in July, and if that's the case, if the subsequent sequencing data demonstrates that this emerged much earlier, that starts to change the modeling about how transmissible this is and where we are in the epidemic.
Dr. Gottlieb, all along, the discussion on how we get to normal has focused on vaccines, and those are clearly critical towards getting us closer to normal if we ever actually realize what normal is. But there's also a lot of discussion now around therapies, and I'd love to hear your opinion on the pills. You have the Merck pill, and then, of course, the Pfizer pill, which looks to be even more effective. How could these pills, because I've heard people describe them as game changers, how could they change the way we look at going back to normal everyday life?
Yeah, I think that they will be significant in terms of changing how we grapple with this. And as you know, I'm on the board of Pfizer. That they have the pill Paxlovid that's in development, and the Merck pill went before an advisory committee a couple of weeks ago. I think it should and will be approved by the FDA. And I think the possibility of having a pill that's got a good safety profile. So the Pfizer pill, which I know better, obviously, is a protease inhibitor. We have a lot of experience with protease inhibitors. It would be short-term administration. People take protease inhibitors for longer-term administration for hepatitis and HIV. So this would be short-term administration of a sort of drug that we understand very well. If it could substantially reduce the risk of progressing to severe disease, hospitalization, death, when taken within the first 5 days of symptom onset, that could be a substantial game changer, I think, both in terms of reducing the impact of this virus, but also changing psychology around it. I think for most Americans who otherwise are healthy and probably at low risk of suffering a bad outcome from COVID, the idea that there's a medicine that they could take if they do get COVID, I think is going to give people much more confidence to go about their lives. And this could be available in quantities that, barring a major epidemic wave, should be sufficient to cover the American population. Supply is going to ramp going into this year. The U.S. government's already done an advanced purchase of 10 million doses of the Pfizer drug. So I think this could be significant. The other drugs that could be significant are the antibody drugs, especially if they could be formulated in sort of a subcutaneous formulation where you can give an injection right in the doctor's office, so it's easier to administer. And that's in development too. The AstraZeneca drug and the drug by Vir Biotechnology look like they're going to be effective against this new variant Omicron. The Vir put out data today, in fact, that looks highly effective against this new variant. And I think we could be using those drugs more effectively by using them as a prophylaxis. So don't just use them as treatment after someone gets sick or as a prophylaxis in someone who's been exposed to the virus, but for the small portion of Americans who are excessively vulnerable to COVID because they're immunocompromised or undergoing treatment for cancer, they're older individuals who might have other comorbid illness. We could be using these antibodies almost like a vaccine where you dose someone every month or two, and it provides a measurable level of protection from getting infected in the first place. That it hasn't been approved for that. It's being used for that. It's available on a compassionate use basis for that. But I think that eventually it will be approved for those uses, and should be, because I think there's a lot of Americans who are excessively vulnerable to COVID. They know who they are. They've basically become prisoners in their home because they're afraid of getting this virus because they know that they could suffer a bad outcome. I think they could more confidently go about their lives if they had the added benefit of this antibody. It's basically like giving an intact immune system in a bottle. For a lot of people, the vaccines aren't going to be effective. If you're someone who's immunocompromised undergoing chemotherapy, the vaccine may not be that effective. You may not be able to mount an immune response to the vaccine or an effective immune response, and getting the antibody is basically like getting an intact immune system in an infusion.
So switching gears here, Dr. Gottlieb, you are and have a history of having hit that intersection between science and government, which is an interesting intersection. And, we've seen since this began a wide variety of approaches by elected officials on how they believe to protect the public. Some of those approaches have worked, some have not, as has been well documented. What are your thoughts on travel bans, which oftentimes seem to be the first approach that people take, and there's currently one in effect right now, and just lockdowns in general of shutting down local economies?
Yeah, look, I don't think we're ever going to do the kind of shutdowns that we saw at the outset of this epidemic. I mean, when this epidemic first started to spread in 2020, we had none of the tools we have now. We didn't have diagnostic tests. We didn't have sequencing in place. We had no therapeutics. We had a completely immune naive population from a virus that we didn't understand. And we saw New York basically on the brink of collapse. I mean, the healthcare system in New York had been breached. And so the prospect that other cities were going to fall similar to New York, I had talked to people in the Trump administration at the time. They said, we don't have the capacity to give any other city the quote New York treatment. It was a comment that stuck with me. I wrote about it in my book. That's why they did what they did. It was never envisioned that shutdowns would be preemptive. It was always envisioned in the pandemic planning that you would shut down some commercial activity, maybe schools, in a reactive way after you had some local spread that you could identify. But we didn't have the tools to identify it. I don't think we ever reach back to those forms of mitigation again. I mean, you could envision if there's a new variant that comes along that's causing excessive disease, you could envision on a local basis, schools closing if there's outbreaks in schools, even some slowdown in commercial activity within a city, but not sort of a simultaneous national shutdown. And frankly, looking back, we didn't need to do that because the virus wasn't spreading everywhere. I mean, we didn't know where it was, but we didn't know where it wasn't. And we wrongly assumed that every region of the US was going to become epidemic, when in fact, what we've seen has been highly regionalized spread of this virus all along. I don't think that the travel bans are prudent. I was critical of the ban on travel from South Africa. I think you can achieve most of what you're going to achieve through requiring vaccination to come into the United States and requiring people to test 24 hours in advance. I mean, that's pretty onerous, but I think it's pretty effective in keeping out infection. What are you going to miss? You're going to miss people who are incubating the virus on their way in, and we've seen some of those cases come in among American residents. But it's inevitable. If there's a virus in another part of the world, you're not going to stop it. I mean, unless you go through very draconian steps that we're not going to be willing to do here, like we see in China and some other countries, you're not going to be able to prevent it from coming here. What you're trying to do is reduce the number of imports, and buy yourself some time so you can get some preparations in place. And I think you can achieve most of that just with limiting travel to people who are vaccinated and requiring testing. So, even if Omicron starts to spread, I'd be very hard pressed to believe that we would reach back towards population-wide mitigation. I think you could see mask ordinances get put back in place, things like that, but not shutting down commercial activity, not in an environment where we have, assuming the vaccines hold their effectiveness. And I'd be floored in a bad way if if we lose these vaccines against this variant based on what we're seeing right now. But with the vaccines, with effective oral therapeutics that should be available in the monoclonal antibodies, widespread testing so we could turn this over, and sequencing at a massive scale. We're sequencing 100,000 samples a week. I mean, the administration's really scaled that effectively. We could manage this.
Last question for you, and this is one that I think all Americans struggle with, and perhaps it's just a symbol of the times, but it seems like sometimes when there are discussions on the coronavirus and all the variants, Omicron being the latest, it seems like people are talking in two different worlds. Where do you go, and where should we go to get good, accurate information?
I get my information. I mean, it sounds sort of hackneyed. I get my information off of social media. I mean, I get a lot of my information off of Twitter. And I did that when I was FDA commissioner too. I used Twitter pretty actively when I was commissioner of the FDA. I both used it to put out information quickly and to put out information that I couldn't get out through other channels because it had a long clearance cycle. And if I was speaking directly, people couldn't censor me. But I also used it to gather a lot of information. And I gathered information by following people who were good enough to share their intellectual property, were good enough to share their insights on Twitter. I mean, if you're following, Jesse Bloom and, Josh Sharpton, you're going to have in Crystal, and people at Hopkins, and you're following Trevor Bedford. And then, you're following Tulio in South Africa, who's doing a lot of the sequencing work. I mean, Anderson at Scripps. Eric Topol does a really good job curating the day's studies that come out. If you're following the right people, you're going to get a pretty good compilation of information in a very quick fashion, and you're going to get analysis. I mean, a lot of these people put out deep analysis that's interpretable, I think, to the lay public because they know they're speaking to a broad audience. And so curating the right set of people who are there to sort of share information and insights and not just, have a political debate on Twitter could be very effective. And, I've carefully curated who I follow over time to try to get insights from people who are very smart, who have a lot of information to share and do.
Well, one thing we can all agree on, I think every one of us could do with no more political debate on this particular topic. Look, Dr. Gottlieb, this has been fantastic. Thanks for your service to our nation. Thanks for what you're doing now, and thanks for being with us today. It's been very, very enlightening.
Thanks a lot. Thanks for having me.
Okay, that's Dr. Scott Gottlieb. Next up, we are going to be talking to a panelist of experts from the Johns Hopkins Bloomberg School of Public Health. And we thank them for joining us today. Dr. Josh Sharfstein Dr. Kawsar Talat, and Dr. Crystal Watson. So thanks to the three of you for joining us today. We appreciate what you do. Let's dive right in if we can. You look at this virus, you all deal with and think about what the American people have been going through over the last 2 years. Let's talk some basic things here. What is the best way to protect yourself so that you're not getting the virus, and as Dr. Gottlieb talked about, we're all may get infected at some point, but making sure that you don't end up in a hospital with a severe illness. And Dr. Sharpton, I'll start with you.
I think the best way is to be vaccinated right now. The vaccines are very, very effective, very safe. And what does the vaccine do? It trains your immune system to recognize and kill the virus when you get exposed to that virus. And we see that the benefits of that are immense. It reduces the chance you get infected, and that means it reduces the chance you could get someone else in your family sick. It reduces the chance you get hospitalized, and it reduces the chance that you die. Now, there are a lot of people out there, they get a lot of misinformation. There's a lot of just false information floating around on social media. Like, I thought Scott Gottlieb was absolutely tremendous. And if you're following the right people on social media, you can get good information. But if you follow people who are telling you lies, then you're going to get lies. And that's really confused a lot of people. I've been volunteering, going out, vaccinating, canvassing communities with low vaccination rates, trying to avoid get around the political misunderstandings that are out there and talking to people. And one thing that I've noticed, I'll just say, is that what is it that helps people? And I saw a question come in: how do you convince somebody who's resistant? And one of the ways I've sort of changed my approach. Initially, I might have been, talking about all the data, kind of like Scott was, like, look at this study, look at that study. Kind of shifted. It's not so much what, the latest study is. I often ask people who they would get vaccinated for. And that sometimes, leads people to take a step back and say, for my mom, maybe because she's older and I'm worried that she could get sick and I saw somebody die, or for my wife who has rheumatoid arthritis, or the stories that you get when you talk to people a little bit more personally and help people see the value to themselves and their families. Sometimes that can make a difference, where I've gotten 125 questions that I've gotten off of Twitter that you need to answer, like that kind of back and forth isn't that productive.
Dr. Talat, let's jump to you real quick. Really, the same question. Dr. Sharpton mentioned getting vaccinated. That's clearly in everyone's best interests. What else can we do to protect ourselves for both the vaccinated and the unvaccinated?
So I have to agree with Dr. Sharpton and with what you just said, Chip, that vaccination is the best way to protect ourselves. And I think for those who are vaccinated, to encourage everybody around them who is eligible to be vaccinated to also get vaccinated, their loved ones, vaccinate their children if they're old enough. Make sure that people who they come into contact with on a regular basis, to the best of their abilities, have access to the vaccine and can get there and get their vaccines and get vaccinated. For those who are unvaccinated, I think, beyond the vaccine, the best way to protect yourself is to continue to wear masks, continue to be socially distanced, to avoid crowded spaces where people are not wearing masks, to avoid places where you are at risk for the virus being transmitted, which really restricts your life in so many ways. And the best way to remove some of those restrictions, again, is to get the vaccine.
Dr. Watson, I'm going to follow up a little bit on what Dr. Talat just said, because there's been a controversy since day one on masks. Obviously, not all masks are created the same. What should you be looking for in a mask? Where should you definitely wear a mask? Are there places where it's okay not to wear a mask when you're in a group? What are your thoughts?
Yeah, I think we know a lot more about masking and the benefits that it provides us in terms of infectious disease transmission than we did at the start of the pandemic. So we have a lot more data on that. And what we know is that masks with multiple layers that are tightly woven fabric or our medical grade masks, those are fairly protective. We know that KN95s and N95s, which typically is what healthcare workers use, the N95s, those are the most protective, but they're not appropriate for every situation. We know that surgical masks are still pretty protective, and people can easily get those on the market now, and that cloth masks that have multiple layers, at least 3 layers, are also helpful. But it's also important not to put yourself into situations where you're in poorly ventilated indoor spaces with a mixed population where some people might not be vaccinated. So trying to avoid those really crowded situations indoors is really important too, because masks, these mitigation measures aren't perfect on their own. So layering them is really important.
Dr. Watson, I'll stay with you, and I'm going to ask you a question that I asked Dr. Gottlieb just a moment ago, because I think it's important. Where do you get good, solid information on this? I know that myself, when I'm following it, that it seems that Israel and the UK seem to put out a constant stream of information that's fairly easy to follow if you dive into it. But where you're a physician, you study this stuff all the time. Where do you get information? What's reliable?
Yeah, I'm actually a public health expert, not a physician, but I do follow this really closely, as do my colleagues here. And I know I'll have to put a plug in for our own institution, the Johns Hopkins Coronavirus Resource Center. So these are the maps that you saw from the beginning of the pandemic. And my colleagues have been doing so much hard work to curate all of this information, all the data from different realms about the pandemic. And so that's one of my go-to sources. CDC still puts out really great information, very reliable. Sometimes it's a little delayed from what we want in the moment, but it's always high quality. And then I think some of the media organizations have also been doing a good job in both reporting data about cases and deaths and other aspects of the pandemic, but also doing some analysis and some data visualization, which is really helpful.
Dr. Sharpton, quickly, same question to you. Best sources of information, obviously, Johns Hopkins. Obviously, when people watch our show here, the forum, they're getting good information, but any place else that a lay person should be looking to kind of understand what's happening?
Well, it is really hard because there are a lot of places that are talking and not all of them are high quality. So it's really hard. I would go with Crystal. I would just point out that it's not just the map that we have at Johns Hopkins, but there are all kinds of very interesting resources. And I'll tell you one that I use a lot. It's called the Consortium for Research on Coronavirus and Compendium. And what they do is they actually take studies, because you see a news article and it's like, latest study shows, left-handed people wearing masks upside down, that's the right way to go, or whatever it is, you're like, is that really true? And so they have a team of people that look at the study and actually judge it and explain in pretty readable text, what to make of the study. And it's all sorted. So you can look up a particular topic. If you want to see, well, what is really the evidence on masks? Or for example, testing in schools, what's the best way to do testing in schools? They'll actually look at the studies and really explain them and give their strengths and weaknesses and say whether, what the bottom line is. And that is linked from that coronavirus.jhu.edu site, and it's called the NCRC, ncrc.jhsph.edu is the direct link. And so I go there because I find like I learn a lot about the sort of, it's like what's behind the study, what's the bottom line from the study. I find that very useful.
Switching gears, Dr. Talat, Dr. Gottlieb mentioned a moment ago that he was originally of the belief that Delta may be the last significant global variant. And then we have Omicron. What are your thoughts, A, on Omicron, but also on, will there be another one of this significance? And will there be multiple variants of this significance?
So fortunately, I'm not as optimistic as Dr. Gottlieb. I do think that we will continue to have variants that are highly significant, especially with so much of the world still unvaccinated. And the best way to prevent the rise of new variants is to vaccinate as many people all over the world as quickly as possible. So Omicron is still yet somewhat of an unknown entity. We know that it is rising very quickly in terms of cases in South Africa, but we don't know how significant it's going to be in the rest of the world yet. We don't know how severe it's going to be. I'm hoping that the vaccines do provide sufficient protection, and the evidence looks like vaccines will provide some sufficient protection against severe disease. Although we're still going to learn more as we're able to do some of the studies that are necessary to learn the details about that. But I think that as long as we have a significant portion of the world still unvaccinated, then we will continue to see more variants.
Follow-up question to that. When we talk about vaccination, and hopefully you can clear this up, and the boosters that follow, is it a recognition that vaccines, the effectiveness lasts for a certain time period? And if that's the case, what is that time period, and does it differ from vaccine to vaccine?
So that's a really good question, and I'm of the, I've been in vaccines for a very long time, and have been studying vaccines for a long time. And for most of our vaccines, we know that they last a lot longer than the antibodies that the protection from them lasts a lot longer than the antibodies that they produce, because there's memory that is induced by these vaccines. And for the mRNA vaccines, for the viral vector vaccines, such as Pfizer, Moderna, AstraZeneca, Johnson & Johnson, they produce really strong memory responses that will protect people far beyond the decrease in the antibody titers. And so I think we don't know how long protection from the vaccines will last. It is true that we'll get some breakthrough infections. Generally, they tend to be mild unless you're older or immune compromised. But I think that the vaccines will protect us against severe disease for a long time, as long as the variants are still remain susceptible to the vaccine.
Dr. Watson and Dr. Sharpton, I want to ask you that same question, and I want to make sure that I'm clear on this. So the vaccine effectiveness for getting the virus and spreading the virus may wane over time, but the memory cells and the ability to fight severe disease will last for an extensive period of time. Is that your experience, Dr. Watson and Dr. Sharpton?
One thing I'd say, and this is not just this vaccine, this is a phenomenon of a lot of vaccines, is that the strongest protection that lasts the longest is for the most severe disease. And the weakest protection that lasts the shortest is for the mild disease. So what we see is that you can start after 6 months or so, you start to see more breakthrough infections. But as Dr. Talat said, for the most part, they're pretty mild. And there's a reason why this happens, that the most significant long-term protection is for the most severe disease. And that has a root in the way the immune system is constructed, that it's the antibodies that give you the protection for just the infection, the light infection, but it's these memory cells that give you that protection and rise to your defense right when you need it before you get severely ill. And so it's not just what we're learning about this virus and this vaccine that gives us confidence, it's the whole science of vaccines and evidence from a lot of different kind of vaccines. For example, the flu vaccine doesn't actually keep you from getting a little bit sick all that well, but it really reduces the risk of being hospitalized or dying from flu. And so there are multiple vaccines like that. That's why it's such a good idea to get vaccinated if you're worried about these severe outcomes like hospitalization and death.
Dr. Watson, thoughts on that?
I don't have much to add. Dr. Talat and Dr. Sharpton are more expert in this than I am, but I do think kind of the cadence of updates to the vaccine boosters and whether we have a longer term vaccination schedule, it will look different in the pandemic period versus hopefully once we reach a more endemic status. And we don't have a good idea of what that looks like yet, but we will continue to learn more.
Dr. Sharpton, coming back to you again on a question that is asked every day across this country, which is better, natural immunity or vaccine immunity? Does one last longer? And if you do have natural immunity, do you gain greater protection based upon the severity of the infection to begin with?
So
if that makes sense.
Yeah, it's a great important question. It is on people's minds in one form or another. And I think also I'd be interested in how Dr. Talat would respond to this. But for me, the way I think about it is when you get a vaccine, you're getting a lot of immunity. You know you're getting immunity. Everyone's getting the same dose of the vaccine. It's been studied in tens of thousands of people, exactly that dose. But when people get sick, they get sick in all kinds of different ways. They get milder illness, slightly severe illness. Sometimes their illness triggers their asthma or something, and it's everything looks different. And so it's not quite the same as getting the same amount of virus in your body, or in the case of a vaccine, the viral particle in your body, so that you can actually be confident that there's consistency. So the way I explain this is, you're basically gambling if you're relying on your immunity from having been sick. You don't know whether your immune system is really ready to fight the coronavirus, or just, kind of a little bit, and you're really quite vulnerable to getting sick. There's a big variation. Some people out there who were sick with COVID before are going to have a lot of protection. Some people are going to have almost no protection. So, are you a gambler? And I was recently doing a podcast with a host who wasn't vaccinated, and we talked about this, and he said, I am a gambler. I go to Las Vegas all the time, and I said, like, okay, you gamble with your money. What else are you ready to gamble with? Because the evidence is very strong that somebody who doesn't know and is worried that maybe they didn't get the protection from having been sick before, if they go ahead and get the vaccine, no matter wherever they started, they're going to get a lot of protection from the vaccine. So if you want to gamble with your life, you can rely entirely on the natural immunity kind of idea. But the truth is, some people will have a fair amount of protection and a lot of people won't. And better to be safe than sorry. That's why the vaccine is recommended for people who've been sick before.
Dr. Talat, following up on that answer, is there a way to test for those memory cells, those T cells that we've been talking about, whether they come from natural immunity or from a vaccine? Is there, let's say that you were infected, you had a severe case, then many months later, you want to see if there's any protection left. Let's say you got vaccinated and 8 months later, you want to determine how much protection you might have. Is there a way to test that?
Not easily, no, and it's not commercially available. So those are research tests that are really hard to do, which
Right.
is why measuring antibodies is really easy, which is why a lot of our tests are based on antibodies, and that's what we follow. But the measuring memory, measuring T cells, and T cell immunity is much harder to do, and only done by certain research labs, and would be really hard to commercialize and scale up. And we also don't have a sense of what level is protective. You can find memory cells, but is that what you need to be protected? We don't know that information yet. To follow up on what Dr. Sharpton said, the best protection for people who've had previous infection is to actually get a vaccine after they've been infected, because their antibodies are the highest of anybody's, and they become very well protected after a previous infection. We know with Omicron that people who've had Delta in South Africa are getting reinfected with Omicron. So we know that it doesn't protect them against reinfection. So it's really important to get the vaccine.
Yeah, and South Africa is an interesting test case because so few people there have actually been vaccinated, right?
Right, but 80% of people have antibodies, which means that most people in the country have been infected with the SARS-CoV-2 virus.
Yeah, I mean, and the thing that's really heartbreaking is that people can believe things like, oh, if you've had it, you don't have to worry about getting vaccinated, or, the vaccine isn't really going to help you against any of the variants, or things that are just not true. And then by the time they get so sick that they realize their life's in danger and they start asking for the vaccine, it's too late. You can't vaccinate then. That's sort of this really tragic circumstance. And you see these just tragic videos on social media, people, wishing they could get the vaccine, but it's too late. And, it's really important to spread good information, to refer people to good sources of information. And I saw the question about the hospitality industry. The more people who are vaccinated, by a mile, it's safer for every single thing the hospitality industry is going to be able to do. Every discussion that you have gets easier if people are vaccinated compared to not vaccinated.
And that's a perfect segue to our final question. Look, our industry needs people to travel. There's no question about it. We wouldn't be having this conversation if people weren't traveling. And people coming back to work, so that business travel happens. As we think about that, people getting back to their normal travel life, and many people are, and many people did this summer certainly for leisure travel. What are your thoughts on how people can do that in a safe manner so that we never find ourselves in this position again of having to restrict travel and encouraging people not to travel, because we don't want to be in that position? I'll go in reverse order. I'll start with Dr. Watson.
Yeah, I think as we talked about a little bit before, we know a lot more now about layering mitigation measures. So having the vaccine, wearing a highly protective mask while you're traveling, not putting yourself in situations where there's little ventilation indoors, testing before and after you travel. Those are all things that are going to greatly reduce risk. So I think implementing those both personally and expecting them within an industry is really important, and it's going to help us even in the next pandemic. We know those things now. So,
Dr. Talat, your thoughts on traveling and how we can do it safely?
I completely agree with what Dr. Watson said. Also, having tests be easily available and easy to use is really key. One of my colleagues went to a meeting where everybody tested every morning, and then they took their masks off and had a normal meeting. And so to have readily available, easy to use tests that are accurate will make traveling much easier, in addition to all of the layering that Dr. Watson mentioned.
It's interesting that we come back to this. I remember hosting one of these programs at the very outset, and it was universal with the panelists. We need accurate, affordable, reliable testing. And here we are, 20 months later, we need accurate, affordable, reliable testing. It's so as much as things change, they do stay the same. Dr. Sharpton, I'm going to close with you, and I'm going to switch the question up because it's something Dr. Gottlieb and I talked about, and we both called it a game changer. Do you believe that these pills, the Pfizer pills specifically, could be the game changer in the way that people psychologically approach the virus?
I do want to end on a positive note, but I would say that I'm a little nervous that the politics and the polarization that have affected vaccines could unfortunately undermine the advantage of the pills. The pills are terrific. If the evidence bears out, they will definitely be helpful. But if people don't believe coronavirus exists, or they feel like it's, admitting defeat to go into the doctor to get tested, then they won't be able to get the pills in time. This is something that is really important, that those first 5 days are when these medications really work. After that, the problem isn't so much the virus, it's the overreaction of the body's systems to the virus that cause the problem. And just taking the medicine when you're really sick in the hospital, it's too late. And so it's really important for people to pay attention to COVID, to be reasonable about it. If you're feeling sick, to get that test, and then to be seeking out the medicine. If that happens, it will be a game changer. And it's really important, though, to get to that point for people to get past all that misinformation, to get vaccinated where they can, to be ready to use tests, basically to engage. Like, what was amazing with Dr. Gottlieb's talk is like how much science that guy packs into 10 seconds of speaking. It's remarkable. You could diagram it. It's a tremendous amount. We all need to benefit from that science. We need to benefit from the tests and the medications and the vaccines. If we can somehow overcome the divisions and say, let's benefit from the science, it'll really help. It'll be an extra part of the piece of the puzzle. But if we remain in our kind of corners and misinformed and misled by lies that are out there, then I'm not sure this is going to help as much as we might hope, because people won't get it when they really need it.
Well, let me say, we have all benefited by having you for the last half hour or so. To Dr. Sharpton, Talat, and Watson, thank you so much for being with us today. And more importantly, thank you for what you do to help all of us here in the United States and around the world. So we appreciate your time today. And to everybody that participated in this, I want to thank you as well. And our last thank you, of course, goes to our sponsors. Without them, we wouldn't be able to do this. So again, thank you to Food Buy, Hodges Ward Elliott, and Spencer Stewart for their support of the forum series. We appreciate everyone's support of the American Hotel and Lodging Association, and we'll see you again next time on our next forum presentation.